Good, good morning, good evening, good afternoon, good day, all the audience. My name is Alice. I will be your host today. Thank you for being with us in the next wonderful hour. Before I start introducing our speaker, I would like to give all viewers a brief introduction on who we are. We are a global team of mentees from the International Leadership and Mentoring Program organized by Professor Nguyen Hong, and we are very lucky today to have him with us tonight. And let's invite Nguyen Hong, Professor Nguyen Hong, to say hello to the audience.
Hi, good morning, good afternoon, and good evening. Welcome to another session of a Global Leadership and Mentoring Program. Today, we are very privileged to have my old friend, Professor TAOFEEQ from Africa, to join us. And the first time we have an African to join us in the mentoring program. Just a brief history, we started about 2016. I always have a passion to help and to nurture early career medical physics throughout the world. I travel pretty extensively to all the continents, except Antarctica, perhaps, yet to be there. And I team up with a couple of people, Professor Thomas Krohn, Professor Eva Bizak, amongst the others, to start this program. So it's not my effort alone. They help us to get started. So the idea is to develop leadership among these early career medical physicists and provide an environment for them to interact with each other, also the support system. And I always believe in the intercultural dialogue. It's so important. So we have our mentees from across, from Asia to Africa, Europe, and to the Latin America. It's pretty good. We started about 12, so we now have about 20 over mentees, and they're all very active in different activities. So today is one of the activities that they engage in, and they also have projects. They publish papers together and various research, also helping one another. It's a very good support system. So that's briefly about the Global Leadership and Mentoring Program. And welcome again, my old friend TAOFEEQ. We always bump each other in the various world congresses in different cities in the world. It's amazing. So over back to you, Alice.
Thank you, Professor Ng. Just like what Professor Ng said, we are International Leadership and Program Mentoring Program Group, a group of young, passionate young medical physicists as mentees, and a group of warm-hearted mentors from different countries who are eager to bridge the gap cultural and foster international tie beyond our local medical physics community. And our group will routinely organize monthly meetings with various topics that aim to encourage young medical physicists to grow as future leaders with the help of the mentoring system. To know more about us, you can easily find our webpage, Facebook, and Instagram link down below the this YouTube page. The description, you could find the link of our YouTube and the webpage and Instagram link. And please like this video and subscribe and follow us. And then you could have the access to our upcoming webinars and see more our past records, so many fun topics that you can find on our YouTube channel homepage. So thank you for making time with us. We are always happy to have you. And about tonight's meeting, we will be taking questions at the end of the 40 minutes talk. If you have any questions or comments, please feel free to leave your message in the chat room, in the comment section on the YouTube video page. And today's speaker, Dr. TAOFEEQ, he's the head of medical physics department in National Hospital Abuja. He's also the ex-president of FAMPO, Federation of African Medical Physicists Organizations, and it's our privilege to invite him to share his valuable experience on establishing a medical physics department. And without further ado, let's welcome our speaker of today, Dr. TAOFEEQ. And today's topic is starting and setting up a medical physics department, challenges and lessons learned. Let's welcome Dr. TAOFEEQ.
Okay. Thank you very much, Alice. Okay. Thank you very much, Alice. And good afternoon here. Good evening on your side. Good morning for the other people around the world. I'm really delighted to have Professor Hung sharing this meeting, with us. So thank you, Prof, for your mentorship. We are really, really very delighted, to have you every time. So with that, let me quickly try and share my screen. I hope technology does not fail us today.
It's pretty your screen.
Yes, so. Okay. Okay, so let's see. All right, so we'll go back here. Yes, okay. So share now. Yes, okay. Good. No, this is not what I want to share. No, not this. Sorry? Screen is already showing. Huh? Open the PowerPoint. Entire screen. Oh my God. Okay, I should open the PowerPoint. Where is it? Okay, yes. All right, so Alice, can my PowerPoint be seen?
No, Dr. TAOFEEQ, did you press the share button?
Yes, I did. So you cannot see it?
Yes.
Wow. Okay, this is the share button.
Share button, share screen, and then I could choose the window that you want to share.
Okay. Window, yes. I think you may see it now. Yes, are you able to see it now?
Yes.
Are you able to see it now?
Play. Yes, yes.
Okay, so let me proceed. Let me proceed quickly. Once again, good afternoon, good evening, good morning from different parts of the world where we are listening to this talk today. First and foremost, I want to thank the mentees, the Medical Physics Leadership and Mentoring Group for inviting me to make this presentation today, trying to share my experience in starting and setting up the Medical Physics Department, challenges, and then the lessons learned, So the presentation outline is going to go like this. I have a two-slide introduction. Then we'll quickly look at the global MP workforce, the roles and responsibilities of medical physicists as defined by the IOMP, the African medical physics landscape, and then medical physics in Nigeria. I then move on to the main experience that needs to be shared, with some acknowledgement and then my references. So as a form of introduction, the GTFRCC has actually indicated that the workforce shortfall in LMICs, including Africa, has been highlighted by the GTFRCC. And it identified the need for new approaches to train radiotherapy professionals particularly has been essential, with an estimated 7,500 radiation oncologists, 20,000 radiation therapists, and 6,000 medical physicists needing to be trained for LMICs by 2025. We are just 4 years away, and we are looking at 6,000 medical physicists. I think it's a tall dream. Now, using current staffing models, this report estimates that by 2035, an additional 30,000 radiation oncologists and over 100,000 technical personnel, as well as clinical support and research staff, will be needed worldwide. Now, the essential healthcare system expertise and infrastructure needs and the benefits that will be derived from filling these healthcare gaps make this a formidable and compelling challenge. Mentorship, as being displayed by this group here today, is recognized as an important element in healthcare training. Leveraging the expertise and mentorship of senior experts can alleviate this shortfall in no small measure. And this is why we want to thank, and we cannot thank Professor Hung enough for actually coming up with this initiative. Moving on with my introduction, in an ongoing study which we are publishing shortly by TAOFEEQ A and Manjit Doshan et al., the need to prioritize radiotherapy within national cancer strategies extending to workforce planning has been further highlighted. Now, there's clear evidence from results obtained that there's a lack of training programs in all radiotherapy disciplines, and there are issues with retention of staff who have achieved specialized training. That's the brain drain syndrome. Now, the role of the IAEA is pivotal in addressing this, and their supporting access to educational opportunities was indicated by many of the countries surveyed by the work earlier mentioned. Now, bridging the gap to the creation of national degree awarding programs requires government buy-in and incentivization of students to become part of the cancer workforce. Now, wide variation in facilities across African nations exists, and significant disparities between training and educational opportunities. Now, in terms of education and training, the overarching sentiment was a lack of standardized curriculum, formal education and training programs. Now, higher degrees in radiotherapy-related disciplines are not widely available in most of our member states. Even within our member states and nations, there are still disparities even in the curriculum, which the IAEA has tried to ameliorate by coming up with the HHS 25.
This is TAOFEEQ.
Yeah? Yes?
Can you hear me?
Yes.
Could you please play your PowerPoint? Because we are now seeing an edit mode, not a playing mode.
Sorry? You are not seeing?
We can see your PowerPoint, but it's in an edit mode. We want to see a display mode. Could you play your PowerPoint?
I should play it.
Yes.
Huh? Okay. Huh? Slideshow. Okay. All right.
Yeah.
From current slide, right? Okay. Yeah.
No.
Okay.
Yes.
Is this better?
Yes.
Alice?
No, it's still on an edit mode, not sharing. Could you please share your screen again on the StreamYard page?
The StreamYard page, and I need to. Wow.
Yes, you need to share the screen that is like a displaying your PowerPoint.
Okay. This StreamYard share, is it? Okay. Oh no, my God. Share. It's telling me to stop sharing. No, I want to share.
You can stop sharing first, then share it again.
Okay. Shall I stop or just go ahead? Stop screen and then start again?
Yes.
Okay. All right. So I share again, right?
Yes.
Okay. So share screen.
With the screen of displaying PowerPoint.
All right. Okay. Windows here. Okay, Windows. Yeah. All right. Okay. And then here. Okay. Alice, how about that?
It's still in the edit mode, not a display mode. But I think it's fine. We could continue if we can fix this problem.
Okay, all right. So sorry about that. I mean, but
It's
can you
fine.
see the screen?
Yes, I can see the screen. I can see the PowerPoint.
Okay, good. So that's the RMP published work in 2018 indicates the global medical physics workforce. And by the way, the RMP, to a very large extent, most of the medical physics students and colleagues all over the world, I just want to bring this about RMP, representing about 20,000 medical physicists and with 82 affiliated national member organizations, 6 regional organizations, including Afro and FAMPO on this side. So how many medical physicists will be needed for a radiation service, medicine service? I think that has been indicated by the UNSCA report in 2008, and it's exactly following the same trajectory over this number of years. Now, to the roles and responsibilities of medical physicists, as defined by the RMP, the principal functions and responsibilities of medical physicists can be summarized as follows. The establishment and implementation of healthcare technologies with emphasis on patient diagnostic and therapeutic procedures, supervision of radiation protection and safety programs, measurement of radiation, establishment of implementation and supervision of quality assurance programs, up to technical supervision, and then research and teaching. Now, looking at the African countries with medical physics societies, that's African countries landscape, we have about 10 countries with the societies, with medical physics societies, and this was highlighted in a published work early last year with the number of medical physicists as indicated, in the table, by the side. Now coming to Nigeria, the medical physics in Nigeria, from the education perspective, we have 7 universities currently, at least about 1 or 2 more is joining shortly, running postgraduate program in medical physics, and about 95% of practicing medical physicists today in Nigeria have at least a master's degree, which is from the HHS 25, has been brought about to be the basic minimum that should be expected now for any physicist aspiring to come into the clinics. In Nigeria, no university runs an undergraduate medical physics program, although it's being currently considered by the National University Commission. We'll see how that goes. Now, the ongoing clinical residency program have been plagued with challenges and sustainability issues. I'm going to touch on that towards the end of this presentation. Now, with respect to infrastructure, right now, there are about 12 radiotherapy centers for a population of about 200 million. It's actually, we must say that's grossly inadequate, but that's exactly where we are now, with 8 public and then 4 private, as indicated. In all these centers, we currently have functional 7 linear accelerators, with more than half of these machines in just 2 centers of the country. Now we have 3 Cobalt 60 machines, preponderantly in the private sector. Just 1 in the public, that's the UCH Ibadan. And that's the graphical distribution of the facilities in the country. You can really see that there are quite some areas, that need to be populated. With respect to brachytherapy, we have 9 high dose rates. 6 of them are being put together to be commissioned into service shortly. We have 4 nuclear medicine centers, essentially 2, because the other 2 centers only have Geiger counters for RIA studies. And about 200 scanners, as at the end of the last year, CT machines we have in the country, with more than half in the private sector. Now, coming back to the establishment of this department, which is the only one of its kind in the country, It's one of the latter additions to the clinical departments in the National Hospital in 2005, and only one of its type in the country. And up till today, as we speak, in any tertiary health institution in this country, it's still the only one. Now, the department was created in a management continuous bid to improve the efficiency and effectiveness in the service delivery to Nigerians and citizens of other countries patronizing this infirmary. In the earlier times, at least, we have patients coming in from neighboring countries like Cameroon, Niger, and so on and so forth. Now, the department needed to function as part of the radiotherapy and oncology department, but because the services are extended to the radiodiagnostics, dental and maxillofacial surgery, orthopedic surgery, and nuclear medicine departments of the hospital, the then leadership of the hospital actually went along with us to really see that this department was created. And then one of the challenges we had at the setting up of the department then was our colleagues who are supposed to be supporting us felt, probably, why do you set up a two-man department? You know, because it was only me and my senior colleague who were then here. But by the year, 5 years later, the department workforce has grown, as shown, and the material resources then was, we have a big water phantom for beam calibration and a smaller phantom for the same purpose, together with a dose checker for a quick beam output check. We also have dosimeters and 2 PTW electrometers for dose measurement, as well as a Staunton 90 stability check source for the cylindrical chambers. The IAEA had hitherto donated a non-invasive X-ray test device, as well as a collimator and beam alignment test tools for quality control of the radiodiagnostic facilities in the country, which is also hosted by the department. So we're able to seize that opportunity to do most of the QA, QC in our very fledgling radiodiagnostic department. With respect to the activities and services of the department, then the department strengthens the safe and effective application of advanced technology to the diagnosis and treatment of diseases through collaboration with the above-mentioned departments, through the periodic and scheduled quality control tests and QA of the high technology facilities in the hospital, which include, among others, then the multi-energy linear accelerator, the CT, the superficial X-ray unit that time, you know, which was the PANTAC, the simulator, the mammography unit. Oh my God. Wow, that's really, okay. Okay. Please play your PowerPoint. It's 15:10. Wow. Again, sorry. Alice?
Yes, I'm here.
Okay. Can you see my?
I can hear you. Yes, I can see your screen. It's on the first page.
Yeah, but we probably need to just move on quickly to where I stopped. Well, I understand, I got the impression that the screen is not being seen. Are you seeing it now? Alice?
Yes, I can hear.
Can you see it now?
Yes, I can see it now very clear.
Clearly, okay, all right, okay. Well, that's where I was anyway. You know, in the year 2010, the department actually planned about 278 patients on external beam. We have 14 on low dose ray brachytherapy sessions, and then 5 were treated for through the radioiodine capsules. With respect to the training activities, Professor Pipman of WAPM visited Nigeria in that same year. The visit was at the instance of the medical physics community in Nigeria, and the National Hospital, being the custodian of the only medical physics department in any tertiary health establishment in the country, played the role of a host. So the expert visited 4 other radiotherapy centers in Zaria, Ibadan, Lagos, and Sokoto. He gave series of lectures in the course of his 2 weeks visits in the above-mentioned centers, culminating in the paper he delivered on the first day of the IAEA-sponsored regional training course on fractionation in clinical radiotherapy, titled 2D to 3D conformal radiotherapy and to IMRT, a progression and its relation to fractionation. The expert, an emeritus professor, also donated some relevant book titles to the department. He was then the chairman, Latin American Affairs Subcommittee and International Affairs Committee of the WAPM. He's a member of the Joint College of Medicine at Yeshiva University in New York, and currently Professor Pittman still holds some posts in the WAPM, and recently is the past president of the medical physics NGO group, medical physics. Now, with respect to the training activities, the department organizes weekly lectures for her staff and interns to students on short visits. It also participates in the training of the radiotherapy technologists and the nurses in the radiotherapy and oncology department, which was the sister department. Now, it enhances training for resident doctors, medical physics nurses, and other allied staff locally, internationally, and in the application of physics in medicine. Now, limited numbers owing to space constraints of undergraduates as well as postgraduate university students are also entertained for student industrial work experience scheme and clinical attachments in the department. Being the only department of its kind in the country, we have to bend backwards most of the time to really accept this request. For example, in 2010, these are the training courses and conferences attended by staff, in the department. And that follows, year in, year out, mostly via the assistance of the International Atomic Energy Agency. Now, with respect to the constraints and challenges way back then, the need to upgrade the manual treatment planning that were used to then to the computerized treatment planning regime with the acquisition of a 3D treatment planning system for the Linux and our brachytherapy machines to enable efficient use of these facilities and optimizing dose delivery to our numerous patients. Then we are still very desirous of acquiring a TLD reader, for the hospital-wide personnel monitoring. I want to say that at least today, the above challenges have since been surmounted with the acquisition of the 2 Linux, which were commissioned in 2017 and 2019, and the optically stimulated luminescent dosimetry equipment and accessories, which was donated by the IAEA in 2015. Right now, the National Hospital Abuja has 2 new linear accelerators, electrical synergy platform with 3 photon energies on both machines and 6 electron energies apiece. We have a CT simulator, a computerized treatment planning system, 2 of them, for each of the Linux. We have the R&V system with Mosaic, and of course, a Sun nuclear dosimetry system. Now, as at 2020, we have 10 medical physicists on site. That's the frontal view of our radiotherapy center. That's the treatment, one of the treatment planning systems. This is the machine, and the back, this is the newest one. The second one is like a mirror image. That's our CT simulator, and that is looking at the area view, of the new radiotherapy at the NHA. And of course, our OSL in our access trace for personnel monitoring is this MicroStar manual. We are still hoping that we may be able to upgrade this to the higher version, such that we are able to do most of this reading of the badges automatically and with higher throughput. Now, being the only medical physics department in the country, looking at this as a hub for the National Medical Physics Residency program that's ongoing. Of course, in the country, as part of setting up this residency program, the IAEA has actually, as part of the discussions leading up to the starting the residency program, as is going to be seen in the chronology of events that led to this, encouraged all the universities in the country to follow this HHS agreed education and training scheme. And looking at the Afro academic training guidelines, these are the core, recommended, and elective courses and modules that have been put forward. And this, through the National University Commission, probably the various universities are being encouraged to follow this so that we'll have a standardized and harmonized training curriculum. And that's the Afro clinical training guidelines. I mean, the one of them, the TCS 37, is the one that is being implemented now for the clinical residency program. Now, the residency program, the implementation, just like I mentioned, is the TCS number 37 of 2009, which is the clinical training of medical physicists specializing in radiation oncology. The residency program is meant to complement the existing academic program, in the country. Unfortunately, we started this program, and then about 6 months later, the Afro program actually came out, but we were not able to go back. And of course, we have since made some progress, although it may be, considering the number of years that has gone by with a lot of challenges, 6 of the first 6 modules have been substantially covered that eventually led to the examination, because we have to break down the residency program to part 1 and part 2, which is similar to what we have with our clinical colleagues in the country. And by the way, that's the chronology of the Nigerian National Medical Physics Clinical Training Program, all the background work that led to the commencement of the program 9 years ago. The milestone reached is as stated, culminating in the part 1 assessment exam in 2015, out of which then 7 of the candidates, 6 out of the 7 candidates that started the program start for the exam. The other one, just part of the brain drain, he was meant to go for a program in Texas and never returned back again. Out of the 6 that sat the exam, 5 passed and 1 failed. The challenges were that we have dearth of clinical supervisors, just like I've earlier mentioned, there are only 2 of us here, which is being considered as a hub, although, some other departments are still coming up, and I think probably we may need to really look at this again. There are insufficient TAOFEEQ equipment and accessories. There are unacceptable equipment downtimes, way back then. And of course, the budgetary provisions have been so irregular, and this really impacted in no small measure, the entire program. The next steps is that we need to conclude the part 2 of the first cohort. Right now, the IAEA was generous again enough, where 4 of them, 4 of the residents left out of the 7, now remaining 3. The last, in the course of the pandemic, or just before the pandemic started, 2 of them were able to complete the other fellowship in Morocco, and the last one just left last week. We're hoping that by the time this is concluded, arrangement has been made, if not for the pandemic, that the first IMPCB exams will have been held here in Nigeria last year, and that is still on course. So the remaining 3 may be able to sit down for these exams, and luckily, at least some other 2 colleagues who are a little bit senior to the current 3 have on their own attempted the IMPCB exams, and they are just waiting for the part 3 now to be certified. The sustainability is still a big problem, an issue that we need to really tackle with this program. Now, in my concluding remarks and lessons learned, I want to say that in the face of confounding and daunting challenges and obstacles from familiar and unfamiliar quarters, mentees should remain focused, resolute, and strong. I want to mention, without any fear of contrary, that there are still some fertile and uncharted areas and ideas. We need to dig deep, and we may be lucky to come up with another eureka in our own space and time. Now, I've since learned, and that's part of the lessons learned in my over 2 decades in medical physics, to negotiate the bends and challenges on a glorious path to create an impactful moments and situations, no matter how little and insignificant. And my last remark would be to really introduce the MedPhys Leadership and Mentoring Group to the International Cancer Expert Corps as a senior partner in project. We may need to work out the details of this later, because it has been established that mentoring is one of the areas that we need to chart to bring about solving this huge gap in the medical physics conundrum in the world. With that, I want to acknowledge the following entities and people, and thank you all for your rapt attention.
Thank you, Professor TAOFEEQ. This is a wonderful and inspiring talk. We all learned a lot from you. And here are some questions from the audience.
Go ahead.
Okay. Here's one. It's about it's asking you about how do you handle the allocation of resources when there's a machine breakdown as a microphysicist? How do we prepare for the situation like that?
When machine breaks, right?
Yes, about machine breaks. How do you set a plan to solve this situation?
Well, in the earlier times, actually, there's been very serious breakdown, of these few Linux in the country, and we still have some of them that are broken down almost 2 years on now. But since the advent of the commissioning of the 2 machines in my center here since 2017, we've not had breakdown probably more than a month. And since we have 2 machines now, and that's the essence of having at least a dual facility on a site, we are able to migrate our patients, to the other machine, because we have been lucky not to have 2 breakdowns at the same time, which can be obvious, which could really happen, but we have been lucky that that has not really happened. So we're able to migrate our patients to the other machine that is working, pending the time when the other one is fixed, So, and I may want to mention here that there are situations way back about 8-9 years ago, 2012, 2013, where we really don't have any functional machines in the country. But I think we have still really moved away from there, because as we speak now, like I mentioned, my center has 2 machines. There's another center in Lagos that has 3 machines. All right, and the private centers are coming up now. And by the way, the one that has the 3 machines has a 10-year service contract. So at least we are looking forward to in the next 5-7 years, we will not have a situation that we had way back in 2012, 2013 in this country, where we really don't have a place, where the patient really don't have a place to go. And with the upcoming private centers, we want to believe that the private facilities wouldn't allow their machines to go down the way of the government. So that will be my quick answer to that question. Okay, I'm seeing another one. Alice, are you reading it out for me? Oh my God. God, I can't hear you again.
Sorry,
Okay, now.
I
All right.
forgot to open it.
Okay,
Could
good.
you please summarize the key factors of setting a medical physics department?
Wow, thank you very much for that question. I mean, it has been published in several of the Medical Physics Society publications. I'm sure FAMPO has one too. The IOMP has since come up with that. But much more importantly is the buy-in of the leadership of the various institutions where this is going to happen. Because believe me or not, you definitely have issues, even from familiar quarters, because what I mean by familiar quarters is that at least some of the colleagues that you think should be supportive of the coming up of this kind of department may be, and we have seen it in our own case, be one of the strongest antagonists of trying to make it happen. But of course, in our own case, I must credit our chief executive officer at that time. He insisted whether two-man department or no two-man department, this department is going to be created. Because we have seen that the need to create this department far goes beyond, being shackled under a department. Apparently, this is a department that most of the, activity or where at least 70 to 75% of our resources and energies are devolved to. And unfortunately, they are the one who really didn't want the department to be created, but the department was created anyway, So with respect to the factors, that's the key. The other bit has been published, in several publications, and I'll probably refer to colleagues to really dig into that. That would be my quick answer to that, please.
Thank you, Professor. And here is another question from another audience. Do you have comments on how medical physics services should be started in diagnostic department? Does it require the same scale of resources and efforts?
Yeah, because in fact, there are, in terms of spread, there are preponderance of more diagnostic radiology facilities. I want to believe it should be the same across the nations and the continents. But for us, taking Nigeria as an example, just like I've mentioned, we have just barely 12 radiotherapy centers, in the country today. But we have
Sorry, Professor Taofiq, it seems your internet
okay, good.
is
Coming back again. Spread across different tiers of health facilities, ranging from the basic to the tertiary. All right, and it has been shown with the interventional and the advent of more CTs being deployed in diagnostic and clinical use, today, that there is a need to really look at this much more critically, because then the fear is that the risk involved in the radiotherapy procedures are really more. And so the emphasis has always been on that, even from the IAEA perspective. But even from the IAEA now, in the last 5 years, there has been a lot of massive deployment of resources to really take care of diagnostic radiology and nuclear medicine. And well, in terms of what it may require, probably because of the spread, I know that the tools that may be required based on our experience here is not as financially involving. I'm not saying saying it is less, but it's not as financially involving as you need for a radiotherapy facility, So that would be my quick response again to that.
Thank you, Professor. And here is another question from audience. Please, how soon do you think the first undergraduate program in medical physics start in Nigeria, and how many years from now you could envisage?
Can you envisage? Okay, all right. Thank you very much for that question. That's just came up in the last couple of months now. The thoughts by the I really don't know where it is actually coming from. But at least some of our senior professor colleagues, have flown the kite, to say that something like this is in the offering, and trying to get the heads up, at least from some of us in the clinics, to really see whether this is a worthwhile venture or not. This has only happened, especially in the extensive survey that we did as part of the contributors to the IAEA HHS 25 document. It's only in South Africa that we have a BSc Honors Medical Physics, especially in this part of the world. And from the HHS 25, as you have clearly seen, in the charts, it's suggested that the medical physics program should be at postgraduate level. At least the academic bit, just like you very well know, you have to satisfy the academic bit before moving on onto the clinical training. So coming back to your question, my brother, Maiwa, I cannot say because it's just starting. The whole process, I think, needs to be tabled. And I know that for the National University Commission, it usually takes some time. So I'm not in a position to really give the number of years that this may actually happen. It may not, depending on what argument is brought forward for trying to get it established, whichever way, So thank you so much for that. But at least you can private chat me again, so probably one knows what are the other things that are going on in the background to really bring this about. Myra, thank you.
Thank you, Professor. And another question from audience is, what effort are you to harmonize the curriculum in the Africa community?
Okay. Thank you very much, Professor Lassine. The curriculum in the African communities are actually being done, by the Federation of African Medical Physics Organization. So right now we have a published document, both academic and clinical training, which the member states are encouraged through the AFRA, that's the African Region Collaborative Agreement, to follow. So there are no efforts again to be made. It's already harmonized. It's just for the member states trying to key into this harmonized published work, to make the work easier, for us in the African community. So the curriculum, harmonized curriculum, has been established way back, 2013, 2014. And I alluded to this in my presentation because then the clinical residency program that we started, we will have followed the harmonized program that was done, with the FAMPO endorsement, but that didn't come about until we started the TCS 37. So we were not able to go back to that. So that's exactly what happened. The documents are there, and member states are actually encouraged, to try and key into this document for proper migration of workforce, at least within the continent and beyond. Thank you.
Thank you, Professor. And the very last question is, I want to take the privilege of as an host, I want to ask a question. The last questions. We all know when setting up a department, there are a lot of negotiations need to be done, like to the manager level of hospital or to staff, like other physicists, your colleagues, and like therapists, doctors, nursings, um, when we're doing negotiation, there might be some conflicts, and we
Yeah.
all know like communication and solving conflict is like key abilities and key things that we should learn as a medical physicist. So,
Mhm.
what would you give like advice to young medical physicists when we are facing conflicts and try to negotiate? Would you give us some advice and suggestions?
Thank you very much, Alice. Just like I've mentioned, that it has happened in our own case, obviously, we need to, we have to first and foremost make ourselves relevant, in the various departments. That's the first key. Of course, making ourselves relevant, to really know that perhaps there are some key tasks, all right, that cannot be handled, okay, except our professional cadre. An example that I'm going to give here again, permit my little bit of digression, is that the federal government of Nigeria about 15 years ago went ahead, to the first major upgrade of radiotherapy centers, in the country, which is popularly referred to as the VAMED project. All right? And 4 new radiotherapy centers were meant, in fact, one was meant to be upgraded, 3 new ones were supposed to have come up, and it was followed through. The only one that was existing then was Lagos, which was the first one that was upgraded and commissioned, by our then president. Then we move on to Enugu. Unfortunately, the situation there was that, once the thing was commissioned, there was some vandalization, and it has to be even snowballed, because the relevant staffing were not there. But the worst one, the Sokoto one, there has to be some movement of some colleagues, from Zaria, from Abuja, to get that started. But the one that was really very pathetic, was the Bini, and then perhaps the oncologists were there, the therapists were there, but unfortunately, because there are no medical physicists, so the facility cannot start. And then because of the power situation in the country then, these facilities were actually built around using diesel 24/7. All right? There's a big generator during the day when the machines are on, the big machines, the linear accelerator and probably the CT. And overnight, we have to use a small gen, to keep the vacuum on. But here we have 7 months down the line. There are oncologists, therapists, diesel is being burnt, patients are dying, and yet the service cannot start because of no medical physicists. And then it's then become obvious, and that's part of the reason that led to the start of the medical physics residency program by the Federal Ministry of Health. Who are these medical physicists, for God's sake, that are, all right? So it's such kind of relevance, that we need to create. Of course, definitely there will be conflicts. It's part of human nature trying to, okay? But once we are able to make ourselves relevant, and then everybody knows their specs, at least to a very large extent, again, you need, just like I mentioned in our own case, a very strong leadership, who sees beyond all the petty sentiments and all these issues that crops up. So that would be my advice, Alice. I don't know whether I'm able to address your
Yes,
concerns.
thank you. It
Yeah.
seems like everyone like you talk very much. So here is
Yeah.
like pop up another questions from the audience is from
Good.
Professor Jahon. And
Yeah.
have you encountered any issue with the salary scheme of diagnostic metaphysicists in your country, like underpay or overpay situations?
Well, thank you very much, Professor Young. You know, I mean, even the question of remuneration is still a very big issue here because, unfortunately, the medical physics is still yet to have a cadre in the civil service organogram, you know, of the country. So we have a situation right now that obviously you can't say we are being properly remunerated. But the only silver lining that is apparently coming up now, although I don't know how that is really going to play out, is that the few new private radiotherapy centers that are coming up with such a fantastic salary structures, you know, that is probably comparable, you know, to our service that is being delivered. And I'm afraid if this trend continue and there isn't any shift in the public sector, then there might be a migration, you know, to the private sector as it were, because unfortunately, we have not been able to accentuate our figures. I mean, trying to produce more clinically qualified medical physicists as it were, although there's a lot of interest, there's no doubt about it, you know, and I'm hoping that with the current situation that is coming up in the private sector, perhaps the government might be pushed to really do something, you know, about this salary issue, because it's an overarching issue, I must admit, you know. Thank you for asking this question. I think it's a point of interest, I'm sure, to not only my colleagues here, but at least the physicists around the world. Yeah.
Yes, definitely. Cannot agree more. Okay,
Yeah.
thank you, Professor. Because of the time, it's going to the end of today's meeting. Today's talk is very inspiring, and audience asking questions a lot. Everybody enjoy the meeting a lot. So thank you, Professor TAOFEEQ, and
Yeah.
thank you for all the audience, all the participants. And we hope you enjoy the session as much as I did, as we did, and looking forward to seeing you in the next section. So let's say bye bye to the audience. Bye
Okay, thank
bye.
you, everybody. Bye-bye now. I'm
Bye.
really
Bye.
happy to
Bye.
be here. Thanks.
Bye.
Thank
Bye.
you, Prof.
Taufik.
Talk to
Yes.
you
Yeah.
soon. Bye-bye
Thank you.
now.
Thank